Imagine this. You treated a patient with laryngeal cancer with radical chemoradiation. You completely cured the patient. The CT scan is absolutely perfect, but your patient still dies. Why? Today we are exposing the most dangerous trap in head and neck oncology. A hidden trap that kills patients every single day. Many young oncologists look at a small tumor on a scan and immediately prescribe radical chemoradiation. This is a fatal clinical mistake. A preserved voice box is completely useless if it is not functional. If you radiate a larynx that is already failing, you will turn it into a frozen concrete pipe. You will condemn your patient to a permanent feeding tube, endless pneumonia, and a miserable death. Anatomical resectability does not equal functional viability. In this video, I am going to show you exactly how to avoid this massive catastrophe. We are diving deep into the baseline functional assessment for laryngeal and hypopharyngeal cancers. This is not just another boring textbook lecture. This is the absolute difference between truly saving a life and slowly destroying one. Do not skip a single second of this video. Your future patients are counting on you. Let us begin. Hello friends. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi for over 12 years. I have been practicing and teaching oncology for more than a decade. I did my MBBS and post-graduation from CMC Vellore. Then I did my DNB at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. I pursued a fellowship at the Royal Marsden Hospital in London and have later undergone specialized training from the United States. I have published almost 85 research articles and abstracts in PubMed Index international journals. We are currently into our series of lectures on evaluation and workup for laryngeal and hypopharyngeal cancer. This flowchart shows the exact sequence of 11 steps for evaluating laryngeal and hypopharyngeal cancer. You must follow this exact sequence to prevent dangerous staging errors. Phase 1 is your initial visualization in the clinic using indirect laryngoscopy and rigid Hopkins endoscopy. Phase 2 focuses entirely on staging and tissue diagnosis. This includes cross-sectional imaging, direct laryngoscopy and biopsy, pan endoscopy, and a complete metastatic workup. I have covered all of phase 1 and 2 in great details in my earlier videos. Skipping ahead, phase 4 on the far right is your final pre-treatment fitness workup. But today, we will focus deeply on phase 3. This phase establishes a vital functional and supportive baseline before you start any cancer-directed treatment. It includes nutritional assessments, dental prophylaxis, and speech evaluations. However, I want you to look specifically at step 7 at the top of this phase. This is laryngeal functional assessment. This is perhaps the most critical decision-making step in your entire clinical workup. You must remember that a preserved larynx is completely useless if it is not functional. If you blindly administer high-dose radiation of 70 Gray to an already dysfunctional aspirating larynx, you will cause a clinical disaster. You will condemn your patient to chronic aspiration pneumonia, permanent feeding tubes, and an eventual salvage surgery in a hostile radiated field. In step 7, we move beyond simple anatomy to evaluate the actual biomechanical safety of the larynx and hypopharynx. We use objective instrumental tools like FEES, VFSS and video stroboscopy. These tools tell us exactly how the patient handles their own secretions, how they protect their airways, and how their vocal cord vibrate. This specific functional data dictates your ultimate decision between non-surgical organ preservation and an upfront total laryngectomy. Today, we will master every single detail of this functional assessment. We are going to focus entirely on the baseline functional assessment for laryngeal and hypopharyngeal cancers. Before we discuss how to do functional assessment of these cancers, we must first know what are the functions of larynx. Only then we can understand how to assess them. So what are the functions of the larynx and the hypopharynx? Most people assume the larynx is only there to produce speech. But that is a very dangerous oversimplification. Its absolute most critical job is breathing and airway protection. It also assists in swallowing. Larynx acts as a highly complex biomechanical shield for the lungs. It carefully coordinates breathing and swallowing so that you never choke on your food or your own saliva. If a cancer destroys this mechanical shield, the entire respiratory system completely collapses. And this brings us to a massive clinical dilemma in our daily practice. This is the paradox of organ preservation. I want you to listen to me with absolute focus, because understanding this one concept will literally decide if your patient lives or dies. As modern oncologists, we are completely obsessed with saving the organ. We proudly deploy a high dose of radical chemoradiation to cure these cancers without using a scalpel. We feel happy when a patient comes to your OPD for post-radiation 3 months response evaluation with his PET CT and laryngoscopy report showing complete response. We feel very happy that by giving radical radiation, we successfully preserved his anatomical larynx. But here is the terrifying twist. What if you successfully saved the anatomy, but you completely destroyed the function? A preserved larynx is absolutely, completely useless if it does not work properly. Imagine the patient you treated with radical chemoradiation had an already dysfunctional larynx before the start of radiation, and you gave 70 grade 2 larynx. 3 months post-radiation, disease response evaluation says complete response. You have not cured this patient. You have actually harmed him. You have practically guaranteed that he will suffer from chronic life-threatening aspiration pneumonia and chronic swallowing problems, and that means a horrible quality of life. You have most likely made him dependent on a feeding tube just so they do not starve to death and aspirate. You have most likely made him dependent on a tracheostomy tube so they don't choke and aspirate. And inevitably, the organ will fail and you will be forced to perform a brutal salvage laryngectomy in a severely damaged, hostile and irradiated neck. You must never fall into this trap. You must definitely prove that the organ is actually worth saving before you even offer these patients radical radiation. Listen to me very, very carefully what I am going to tell you. You must accept a harsh clinical truth when you deal with laryngeal or hypopharyngeal cancers. Living with a permanent laryngectomy stoma is far better than living with an anatomically intact but completely dysfunctional larynx. Once again, living with a permanent laryngectomy stoma is far better than living with an anatomically intact but completely dysfunctional larynx. An upfront total laryngectomy provides immediate airway security. It allows your patient to eat safely and give them a highly predictable survival outcome. But a preserved, useless larynx guarantees chronic aspiration pneumonia, permanent tracheostomy, and permanent feeding tube dependency. A functional neck stoma after total laryngectomy will let your patient live, but a dysfunctional organ will slowly kill them. Just think about what I just told you on this slide. We just discussed the terrifying reality of saving a completely useless larynx. So how do you actually prevent this disaster in your daily practice? How do you definitely prove that the larynx is fully functional and truly worth saving? You cannot simply guess by looking at the patient from the outside. You cannot simply guess by taking history alone, physical examination alone, by doing sophisticated imaging tools such as CT or MRI. You need highly objective and precise tools before you deem a larynx functional or dysfunctional. This slide shows our complete clinical armamentarium. We have to do a baseline functional assessment. There are exactly 10 essential tools you must know for a comprehensive evaluation. I have organized these 10 tools under 4 distinct headings to make it easy for you to remember. Let us quickly enumerate them. We will discuss all of them in my subsequent slides. First, we have clinical evaluation tools. This includes bedside water swallow tests like the standard Yale 3 ounce and modified 3 milliliter tests. It also includes the comprehensive clinical swallowing evaluation performed by your speech and language pathologist. We will soon discuss why you must be extremely careful with these simple bedside water tests and avoid them as only tool to assess. Next, we have instrumental imaging tools. These are your absolute diagnostic gatekeepers. Under this, we have FEES, Functional Endoscopic Evaluation of Swallowing, which uses an endoscope. Then we have VFSS, Video Fluoroscopic Swallowing Study, which uses imaging fluoroscopy. Then we have video stroboscopy and high definition rigid laryngoscopy with narrow band imaging. These two tools are optical tools which map the exact mucosal spread and vibratory functions of the vocal cords. Next, we have to assess systemic physiology of the patient. A functionally preserved larynx requires a patient who can physically survive the brutal treatment. This includes objective nutritional screening like MUST or PGSGA to catch severe cancer cachexia early. It also strictly requires pulmonary function tests and peak cough flow evaluation. If your patient does not have the lung reserve to physically cough out aspirated food, you cannot safely offer them organ preservation. Finally, we have patient reported outcome measures or PROMs. Patient reported outcome measures are actually validated clinical questionnaires. They are answered directly by the patient, not by the doctor. They tell us exactly how the swallowing and voice problems are already affecting the patient's daily quality of life. There are many questionnaires, but the most validated ones are the EAT-10, MD-ADI, EORTC, and the Voice Handicap Index. You must master all 10 of these tools to make the right clinical decision for your patient. Let us explore them one by one in the upcoming slides. We are now going to discuss how we actually assess swallowing in laryngeal and hypopharyngeal cancer patients. We will start with the most common tools you see in your daily clinical practice. These are the bedside water swallow tests. Water swallow test. You probably used these tests all the time during your general medicine and neurology rotations. In a general stroke ward, these tests are highly trusted. But you must deeply understand that your oncology ward is completely different from general medicine ward. What works perfectly for a simple stroke patient might actually harm your head and neck cancer patient. Let me explain exactly why. Look closely at the two very different approaches for doing bedside water swallow test on your screen. There are two main bedside water tests used in hospitals today. On the left side is the volume stress test. On the right side is the baseline sensory trigger. They look completely different because they are testing two completely different physiological targets. One test measures pure mechanical endurance, motor coordination, sequential pharyngeal constriction, and sustained airway protection under a heavy continuous bolus load. The other test measures a highly specific localized nerve reflex. This evaluates the laryngeal adductor reflex mediated by cranial nerve 10 using a micro volume of cold water to maximize thermal stimulation. You must understand the mechanics of both before you ever use them. Let us first look at the volume stress test. The most famous version of this is the Yale 3 ounce or 90 milliliter water swallow test. In many general hospitals, the nursing staff considers this the absolute gold standard for dysphagia screening. The physical rules of this test are extremely strict. Your patient must sit fully upright at a perfect 90-degree angle. You give them a cup filled with exactly 90 milliliter of water, 90 cc. The strict instruction to the patient is that he must drink the entire volume continuously and uninterrupted. Continuously and uninterrupted. They absolutely cannot stop to take a rest, and they cannot take a breath in between swallows. What exactly will you look for while the patient drinks that entire 90 ml water? You need to actively monitor the pure continuity of swallow. You will need to watch closely to see if the patient struggles, stops, or physically fails to complete the full volume of 90 ml. Immediately after the cup is empty, the assessment is not over yet. You must closely monitor the patient respiratory and vocal response for exactly 1 minute. First, you have to watch and listen for any obvious coughing or severe choking. Any cough is an immediate clinical alarm for frank macro aspiration. Second, you should specifically ask the patient to say "ah" immediately after finishing the water. You will listen very carefully for a wet, gurgly or hoarse voice. This wet voice is a direct sign of penetration, meaning water is actively pulling on the top of vocal cords. If the patient cannot finish the cup, if they cough, or if their voice sounds wet, that means patient has failed 90 ml water swallow test. But you must ask yourself, what is this massive 90 ml test actually checking? It is a pure mechanical endurance trial. Look at the 3 physiological mechanisms involved in this test. First, this test forces the patient to stop breathing for a long time. This forces a transient central apnea. If your patient has a bulky laryngeal tumor causing baseline stridor, they are already struggling for air. This test will force them to take a premature, desperate gasp, pulling all that water directly into their lungs. Just think about that. Second, it forces their upper esophageal sphincter to stay wide open and distended for the entire swallow time. Third, it tests the absolute maximum strength of the pharyngeal constrictor muscle. If a bulky tumor has infiltrated these constrictor muscles, it interferes with normal peristalsis. The throat physically cannot push that heavy 90 ml volume down beyond the mechanical block. This causes a massive backup of fluid directly into the unprotected airway. Now I want you to listen to me very carefully. This is where many young oncology residents make a mistake. The Yale 90 ml water swallow test relies entirely on the patient's cough reflex to tell you if they are aspirating. But think about your patient sitting in the OPD with an advanced T3 or T4 supraglottic tumor. The cancer has completely destroyed the afferent sensory pathways of their 10th cranial nerve. They have profound sensory denervation. Their throat is completely numb. If you give them 90 ml of water, they will aspirate the entire volume straight into their trachea. But they will do it completely silently. They will not cough. They will not choke. You will falsely assume that the patient has passed the 90 ml water swallow test successfully. You will falsely say that, oh yes, laryngeal function is preserved. Because of that one false negative, you will wrongly send that patient for radical chemoradiation. You have just practically guaranteed that they will die from fatal aspiration pneumonia. Just pause for a moment and think about this. Look at the warning on your screen. Using this high volume 90 ml water test in our advanced cancer patients is strictly contraindicated. I want you to imagine a patient sitting in your ward with a bulky T4 tumor or bilateral vocal cord fixation. Their airway is already severely obstructed. They're already struggling for every single breath. If you force an uninterrupted 90 ml water challenge into this mechanically blocked airway, you create an immediate clinical disaster. You introduce a severe and immediate risk of acute asphyxiation. You can cause a complete respiratory collapse right there in the ward. Second, this water swallow test suffers from complete anatomical blindness. It is nothing more than a crude mechanical trial. It might tell you that a patient is aspirating, but it provides absolutely zero information on why they are aspirating. You cannot see inside. You only watch from outside during the swallow and 1 minute after they have drunk the entire water. You cannot differentiate between a completely destroyed epiglottis or a fixed cricoarytenoid joint. Look at the final verdict at the bottom of your screen. This test is obsolete and highly dangerous for our specific head and neck cancer patients. You must never use it for clinical staging. You must never use it for treatment planning. And you must never ever use it to make a life or death organ preservation decision. This is the modified water swallow test. Instead of forcing a massive 90 ml water down a compromised throat, we use a completely different approach. We modified our water swallow test. We take a syringe and draw exactly 3 ml of water. 3 ml. But this water must be strictly cold water. We place this tiny cold water drop directly into the sublingual space or right on the dorsum of the patient's tongue. Why do we strictly use cold water? Because maximum thermal stimulation forces the superior laryngeal nerve to fire. This test is specifically designed to safely interrogate the neural pathways without giving 90 ml of large amount of water to your patient. Look at the right side of your screen to see exactly how this works. First, it checks the afferent sensory loop of the 10th cranial nerve. We are actively checking if this cold water can trigger an instant sensory alarm, which is the protective cough reflex. Second, it checks the efferent motor loop. We are checking if the intrinsic laryngeal muscles can tightly adduct the true and false vocal cords to seal the airway. During this test, you will actively palpate the neck to feel for hyolaryngeal elevation. You will listen very closely to see if the patient coughs, and you will immediately ask them to speak or check if their voice sounds wet. This is a much safer physiological test for the ward. But how exactly do we score it? Let us move to the next slide to find that out. We use a scoring system called Tohara Clinical Threshold. It grades the 3 ml water test on a strict 5-point scale. Let us break down exactly what these numbers mean for your patient who is undergoing this modified water swallow test. If your patient cannot swallow the water at all, or if they immediately start choking severely, they get a score of 1 or 2. This is a massive clinical alarm. It means their protective reflexes have completely failed and frank macro aspiration is happening right in front of you. You must immediately place this patient on strict nil per oral status. Now look at the middle block. What if your patient swallows the 3 ml and does not choke? You must immediately ask them to speak or say ah. If their voice sounds wet, gurgly or hoarse, they get a score of 3. A wet voice is a direct cry for help from the airway. It proves that water has penetrated the laryngeal vestibule and is actively pulling on top of the vocal cords. Now look at the right side of the screen. If the patient swallows successfully and maintains a perfectly clear voice, they get a score of 4. This simply means they have basic competence to swallow a tiny micro volume of liquid. If they can execute 2 more spontaneous dry swallows within 30 seconds, they achieve a perfect score of 5. Many young oncologists see a score of 5 and immediately clear the patient for a normal diet. But you must never do this in oncology ward. Why is a perfect score of 5 actually a dangerous illusion for our head and neck cancer patients? Let us find out that in next slide. This slide shows the diagnostic trap of these bedside water swallow test. On the left, we see the massive 90 ml water swallow test. It is a volume stress test. We already established that forcing this continuous pour into a mechanically obstructed airway is an acute danger. A bulky T3 or T4 tumor creates a severe bottleneck. If you force heavy volume of water into that tight space, you risk immediate acute asphyxiation right in front of your eyes. Now look at the right side showing the 30 ml water swallow test. It is a sensory trigger test. It might seem much safer for your patient, but it hides a very dangerous clinical illusion. This is volume deception. Just because your patient can safely clear a tiny 3 ml drop does not mean their larynx is truly functional. They will still completely fail when they try to eat the continuous heavy volume of a normal daily diet. This silent aspiration trap is the ultimate reason why both of these tests fail in head and neck oncology. Both tests rely entirely on the patient's coughing to tell you that they are aspirating. But your advanced patients have profound sensory denervation. Their 10th cranial nerve pathways are often destroyed by the tumor. They will aspirate the water completely silently. They will not cough, and you will blindly report it as a fatal negative, false negative. Finally, remember that these bedside tests possess 100% anatomical blindness. They might tell you that a patient is aspirating, but they will never give you the topographic data to tell you why they are aspirating. Let us move to the final slide for our absolute mandate on these bedside tests. This is the absolute clinical mandate for your daily oncology practice. Using any bedside water test is strictly contraindicated for making definitive oncological decisions. You must never use them for clinical staging. You must never use them for treatment planning. And you must never use them to decide if a larynx is actually worth preserving. As we have clearly established, these bedside water tests are nothing more than rapid nursing triage tools. They might help a ward nurse decide if a patient can safely swallow an aspirin tablet, but they have absolutely zero utility in a multidisciplinary head and neck tumor unit. What is the objective mandate on these water swallow test? If you are going to subject a patient to 70 gray of radical chemoradiation, you must have definitive proof that the organ works. You strictly require highly objective topographical and dynamic mapping of the entire swallowing mechanism. There are exactly two key tools that can give you this critical information. One is the FEES, or the flexible endoscopic evaluation of swallowing. This is your primary endoscopic tool. It gives you direct high definition visualization of the mucosal integrity and the exact tumor topography. More importantly, it definitely proves if your patient is silently aspirating their own endogenous saliva. Second tool is VFSS, or the video fluoroscopic swallowing study. This is your primary radiological test. This was endoscopic tool and this is radiological tool. It provides a dynamic, continuous, real-time map of entire biomechanical swallow. It allows you to objectively measure hyolaryngeal excursion, epiglottic inversion, and upper esophageal sphincter opening. You must rely exclusively on these two instrumental gold standard. These are your current non-negotiable gold standards to assess laryngeal functions. Now keep this rule permanently fixed in your mind for the rest of your career. Do not ever use a simple bedside swallow test to determine laryngeal preservation. Let us now dive deep into our first true tool, which is FEES. So we have finished water swallow test as our first tool in this list. Before we go on to discuss FEES and VFSS, let us see our second tool in the list. This is clinical swallowing evaluation, which is actually a comprehensive bedside assessment by speech language pathologist. Clinical swallowing evaluation is an important tool. You should not confuse this tool with the bedside water swallow test. We just completely discarded. This is a rigorous, highly targeted bedside examination performed by your dedicated speech language pathologist. Look at the 4 specific things that speech language pathologists actually do at the bedside. First, they perform a comprehensive intake, carefully reviewing the exact history of the dysphagia, the current medical status, and the patient's specific complaints. Second, they physically evaluate the patient's baseline oromotor integrity, assessing the precise structural mechanics. Third, they assess neural early warning system. They systematically test the precise cranial nerves that control the complex mechanics of the swallow. They are actively interrogating cranial nerves 5, 7, 9, 10, and 11. This tells you exactly which neural loop the growing tumor has completely compromised before you even look at a scan. Finally, they do a hygiene audit, a thorough assessment of the patient's baseline oral hygiene and dentition. Let us move to the next slide to understand exactly why this 4th pillar is a matter of life and death in oncology. This is the fatal equation in head and neck oncology. Your speech language pathologist actively look for poor dentition, severe dryness, erythema, massive plaque buildup, and decaying teeth. Why is this so critical? Because if a patient aspirates their own saliva and the saliva is heavily laden with bacteria from rotting mouth, you are practically guaranteeing a fatal aspiration pneumonia down the line. Immediate oral care is clinically mandated to break this deadly cycle. So we have finished clinical swallowing evaluation, which is actually a bedside assessment to be done by speech language pathologist. A thorough clinical dysphagia examination by your speech language pathologist sets your vitals clinical foundation. It is the absolute clinical prerequisite before you move forward with any instrumental testing. Now that we have established this solid, safe baseline with our speech language pathologist, let us finally dive deep into those tools which require some instruments to assess functions of larynx. These are FEES, VFSS and video stroboscopy and high rigid laryngoscopy with narrow band imaging. These are the most important tools you will write in your theory exams and actually use in clinical practice. Let us start with FEES. This is a very important part of our clinical practice when you see a patient with laryngeal or hypopharyngeal cancers and you want to assess his swallowing and airway function. It is not just a routine endoscopy. It is a highly objective test that gives us exact data. This data drives our most important clinical decisions. You must always remember one golden rule with regard to laryngeal preservation concept. Anatomical resectability does not equal functional viability. A preserved larynx is completely useless if it cannot protect the airway. FEES tells us exactly if the airway is safe. It helps us make the first choice in our clinical practice. It tells us if we can safely save the larynx. It tells us whether to safely proceed with organ preservation or to aggressively perform an upfront total laryngectomy. What is FEES? FEES is an highly objective test, not subjective test, done with a special instrument. We perform this procedure transnasally. This means we pass the scope safely through the patient's nose. We strictly use a flexible fiber optic or a distal chip laryngoscope. Remember, it is not a subjective test. It is an objective test. You are not just guessing, saying, yeah, larynx looks functional. Instead, we will objectively assess laryngeal function with this tool. These are the 4 ways FEES helps us. First, we get a direct high-definition view of the mucosal integrity. We must check if the inner lining is healthy or altered by the laryngeal or hypopharyngeal cancers. Second, we must map the exact tumor topography. It means exact tumor mapping. We need to see exactly where the cancer is located and where all it has spread to surrounding subsites of larynx and hypopharynx. Third, we closely observe secretion management. We are going to assess exactly how the patient handles their own natural saliva. Fourth, we check vocal cord mobility. FEES is going to tell you if the vocal cords open and close normally during the swallow. These 4 points give us the exact data we need to make safe clinical decision of whether to proceed with laryngeal preservation treatment option or sacrifice larynx by doing total laryngectomy. Let us start seeing how exactly the FEES test is done and its various phases. Before we start looking at how FEES is done, there is a warning. You must always avoid using topical anesthetics in the pharynx or larynx for doing this test. This is a very common mistake made by beginners. Artificial numbing completely destroys your ability to test the laryngeal adductor reflex. We simply call this the LAR, laryngeal adductor reflex. If you numb your throat, you will not know if the tumor has destroyed the sensory nerves. You will totally miss the risk of silent aspiration. However, we must also consider the comfort of our patients. Look at the exception at the bottom of the slide. If at all nasal anesthesia is absolutely needed to pass the scope, there is a strict rule. You must apply a very minimal dose strictly to the nasal passage only. You can safely use exactly 0.2 ml of lidocaine aerosols. This small amount significantly improves patient's comfort but does not artificially alter the swallow. These are the 3 pillars of objective assessment using FEES. These are the 3 objective things we must check during a FEES test. You must look for these exact three exact points in every single patient. Look at the first pillar on the left side. This is endogenous secretion management. We must carefully observe how the patient handles their own natural saliva. This is a very important clinical red flag. If we see frothy saliva pooling in the throat, it is a very bad sign. Remember our strict oncological rule. If a patient cannot manage their own saliva, they absolutely cannot manage a real food bolus. Second pillar is the sensory integrity. We are explicitly testing the superior laryngeal nerve, which is a branch of cranial nerve 10th. We do this by gently touching the epiglottis with the tip of our endoscope. A healthy patient will immediately close their vocal cords or trigger a protective cough. You call this sudden closure the laryngeal adductor reflex or simply LAR. Finally, look at the third pillar, bolus tolerance. This is the definitive mechanical test of the patient's swallow. We give the patient a standard hierarchy of real foods and liquids dyed with bright colors. We then measure exactly how deep the dyed material drops into the airway. We score this safety level using the 8-point penetration aspiration scale or PAS. Let us now move to the actual steps of FEES procedure. I have divided FEES procedure into 3 phases for better understanding. You will start with phase 1, which is the pre-swallow assessment. In this phase, we do not give the patient any food or liquid. We must first establish a pure baseline of their anatomy and physiology. We insert the endoscope, but we have not given anything orally yet. We start first by checking velopharyngeal competency. We ask the patient to say E and observe the soft palate elevation. Next is the most important and critical part of this phase, which is secretion management. You must watch exactly how the patient handles their own natural saliva. Look for any pooling of frothy saliva in the throat. If you see the saliva dropping below the vocal cords without a cough, it is a massive red flag. Once again, saliva dropping below the vocal cords without a cough, a red flag. This confirms silent aspiration of saliva. Silent aspiration of saliva. This means their baseline airway protection is already severely compromised. Next, we must test the sensory and motor functions. How do we check it? Here we gently touch the epiglottis to test cranial nerve 10. We are looking for a brisk laryngeal adductor reflex or LAR. This reflex is your primary sensory alarm system for the airway. It is controlled by the superior laryngeal nerve, which is a branch of cranial nerve 10. We test this vital reflex directly using the Fees procedure. We do this by gently touching the epiglottis or epiglottic folds with the help of our endoscope. In a normal healthy patient, this light touch triggers an immediate and brisk reaction. The vocal cords will rapidly snap shut or the patient will produce a strong protective cough. This is the exact mechanism in a normal situation that sounds the alarm and stops material from dropping into the airway and then lungs. Now consider what happens when a tumor infiltrates this specific area. If the cancer destroyed this sensory territory, the reflex completely disappears. When you touch the same epiglottis or epiglottic fold, the protective cough reflex is absent and gone now. Patient's vocal cords will not shut and patient will not cough. This is an extremely dangerous clinical finding for the patient. This absent LAR means the patient has lost the crucial sensory feedback loop. They are now at an extreme risk for silent aspiration. They can easily inhale their own continuous saliva or food bolus without even feeling it. This is exactly why we must test this sensory alarm before deciding on any radical documents. During this phase, we also look for any tumor bulk that physically stops the epiglottis from folding backward. Let us move on to see what happens in phase 2 of the Fees. This phase involves the actual swallowing trials. In this phase, we give the patient a specific hierarchy of test foods. This specific hierarchy of test foods simply means we give them different food textures in a strict order, starting with the easiest and safest item like the ice chips and slowly progressing on to the most difficult items like solid food. This way, you can systematically test the exact limits of a patient's swallow without causing an immediate or dangerous aspiration events. We always dye these materials with blue or green food colors. This gives us a very clear visual contrast against the pink mucosa of the throat. We typically start with ice chips. We often use ice chips as our very first test because their freezing temperature provides a strong sensory signal to wake up the patient's swallowing nerves. Also, because they melt gradually in the mouth, they give a weak patient much more time to safely trigger their swallow without rushing. Once ice chips goes down without any problem, we slowly progress to thin liquids, nectar, puri, and finally solid foods. Remember, your endoscope is still inside the throat, watching very carefully what is happening there. it is projected over the TV screen as an enlarged view for you to see clearly. Before the patient even swallows, you must watch the screen carefully. You must look for any premature spillage dropping down into the airway. You must deeply understand this mechanical blind spot of this test. We call this the whiteout phase. Exactly when the patient swallows, the base of tongue pulls back. The pharyngeal constrictor muscles squeeze tightly around the lip of our endoscope. This creates a 0.5 second whiteout on your screen. The camera light is physically blocked for a fraction of a second. You cannot see anything during this exact millisecond. Therefore, you must carefully infer if any aspiration happened by looking at the aftermath. Let us move on to see the third and final phase of FEES. Phase 3 is post-swallow assessment. The 0.5 second of whiteout has just cleared and your TV screen showing endoscopic view will be bright again. Now listen to me very carefully. You must clearly differentiate between two different clinical events shown in this slide. The first is the penetration. Here, the blue dye enters the top of the laryngeal vestibule. However, it absolutely does not breach the true vocal cords. This simply means that the swallowed food or liquid enters the top of the airway but is safely stopped before it falls deeper into the airways. Because the material does not pass the vocal cord, it has not yet entered the lungs. If this happens, we say this is penetration. This is not much dangerous. The second is aspiration. This is a much more dangerous event. Here the material completely breaches the true vocal cords. The dye drops deep down into the subglottis and the trachea. If you see dye pouring into the trachea and the patient does not cough, this is a disaster. A complete disaster. This is the definitive sign of silent aspiration. It being silent does not mean it okay, it is dangerous. Just think about it. This indicates a catastrophic failure of both motor and sensory protection. At the end, you must check for any leftover dye pooling in the throat. We call this residue analysis. You must ask the patient to cough or clear their throat. Their ability to effectively clear this residue will help you exact swallowing therapy plan. Why understanding all these phases is important to us? Listen, we have just seen how to visually identify penetration and aspiration. However, I told you subjective description are completely useless for decision makings. You cannot simply tell your colleagues that, oh yes, the patient aspirated a little bit. You must formally quantify the severity of depth of a airway invasion. Why do this using a standardized grading system called the penetration aspiration scale? We simply call this the PAS. Before we go on further to discuss penetration aspiration score, let us watch a video in which a clinician is performing FEES test on a normal person. This is the entire setup you need for FEES test. Notice that the patient is sitting comfortably upright in a standard chair. Notice there is no radiation machine or radiation exposure of any sort in fees. This test can be performed right in your OPD or even directly at the patient's bedside. On the left, you see the speech language pathologist holding the flexible endoscope. Behind them is the high definition monitor for real-time visualization. But I want you to look very closely at the tray in the front right corner. See here. Notice here that we do not just blindly give the patient a massive 90 ml cup of water. Look at the strict assortment of consistency on that tray. We systematically test a thin liquid, a puri, and a solid consistency like a cracker. Now look at this small bottle the clinician is holding. This is green food coloring. We specifically mix this bright green dye into the liquid and the puris. Why? Because it creates a very nice visual contrast against the natural pink mucosa of the throat. It makes even the most microscopic drop of aspirated fluid completely undeniable. You will see it when I play this video. Now look at the slide showing the actual start of the fees test. On the right side, you see the clinician gently pressing the flexible endoscope directly through the patient's nasal cavity. Notice that the camera does not go very far down. It passes just below the nose to sit perfectly suspended above the throat. On the left side, you see exactly what the clinician is seeing on the monitor. This is your direct, bright, illuminated topographical view of the anatomical pathway. The patient is fully awake. They can speak naturally. They can breathe naturally, and they will now swallow exactly as they would do during a daily meal. You are no longer clinically blind. You are about to map the entire mechanical swallow in real time. Let us now watch a real endoscopy video of this exact patient to see how the normal larynx protects the airway. Unfortunately, I do not have any abnormal fees video to show you. Let me explain you what you will see exactly, and then I will play the video. The endoscope will pass through the nasal cavity and is suspended right above the throat. From there, you will directly look through the flexible endoscope. This will give us a real-time high definition view of the entire laryngeal anatomy before, during, and after the swallow. This specific person has a normal, healthy swallow, but I want you to pay close attention to the rigorous clinical protocol. The clinician will not just give them a random cup of water. He will systematically test a strict assortment of consistencies, starting with a thin liquid, moving to a puri, and finally a solid consistency food item. He will notice the bright green color that he mixed into the liquid and puris to see movement of this liquid and puris very exactly. Then he will look closely at if he can see any green colored liquid going down through the larynx into the airway. That bright green dye provides a very good visual contrast against the natural pink mucosa of the throat. When the patient swallows those different consistencies, the camera allows us to watch the exact mechanical trajectory of that green bolus. If even a microscopic drop of that green liquid breaches the vocal cords and enters the airway, we will see it instantly. Nothing can be hidden from the endoscope. Now let us play the video. See, the endoscope has entered through nose. It has gone beyond the nasal cavity and now gone down into the throat. At this moment, patient has not been given anything to swallow. You can see supraglottis anatomy. You can see a very healthy and nice pink mucosa. Now patient is only doing a normal speaking. Watch how the entire laryngeal structure moves when he speaks normally. See the vocal cord moving during when the patient speaks. Now the patient has been given colored liquid. See exactly when he swallows that liquid. The liquid goes down exactly where it is supposed to go. Did you see that green color liquid for a moment? It has gone down into the esophagus. Now you are not seeing any drop of green liquid entering into glottis. If there was cancer there, you would notice the green liquid going down into the glottis and in severe cases entering through the glottis into airways. Now the patient is given a higher consistency food item, puri, which is thicker in consistency than water. You can see the patient is swallowing it well. You can see small amount of green color pooling in supraglottis for a very brief time, which is normal. Now this patient has been given solid food. Look how the entire anatomy moves when she chews. Look, he's swallowing solid food nicely. You see absolutely no green color remaining in the larynx. There is no pooling anywhere. No green color is entering through the glottis. Let us watch this video again closely. Endoscope entering through the nose, reaches supraglottis, vocal cords moving nicely when he speaks, green color liquid given, it goes perfectly in the esophagus. There is no green color liquid going into glottis. Now semi-solid food puri is given. It also goes down in the esophagus. You don't see any green color in the throat now. Now a solid food is given. He is chewing it. Now swallowing it. You can see no green color remaining in the throat. Watch this video a few times to get familiar with the entire process of FEES procedure. This is penetration aspiration scale or PAS. This is an objective 8-point scale that measures food bolus tolerance by the patient during FEES procedure. This section shows normal to mild dysfunction. A score of 1 means the material does not enter the airway at all. In these two scores, the food material enters the airway but stays above the vocal cord, above the true vocal cord folds. The patient successfully ejects it from the airway. These scores indicate a structurally competent larynx. Good, healthy and functional larynx despite having a cancer. These patients are your ideal candidates for organ preservation therapies. You can definitely go for radical chemoradiation. They will tolerate tough period of radical chemoradiation, recover well and will preserve the laryngeal function once if they are cured. Now look at scores 3, 4 and 5. This represents moderate dysfunction. You define this specific dysfunction as penetration. Score 3, 4 and 5 is called penetration. A score of 3 means the material enters above the folds but is not ejected. When a patient receives a penetration aspiration score of 3, the swallowed material enters a specific anatomical space called the laryngeal vestibule. Because the material is not ejected, it means the patient fails to clear it out of the airway. For example, by coughing or clearing their throat. As a result, the material simply remains pooled or resting inside the laryngeal vestibule, sitting strictly above the true vocal cords. As long as the material stays in this location and it does not completely breach the true vocal cords to drop deeper into the trachea, the event is classified as penetration rather than aspiration. However, leaving material sitting in the vestibule without ejecting it is a sign of moderate dysfunction and is dangerous. It places the patient at a very high risk for later aspiration if that leftover residue eventually spills down into the lower airway after the swallow is finished. A score of 4 means material touches the vocal folds and is successfully ejected. Let us look closely at what a score of 4 actually means. This score means the food or liquid drops deep into the laryngeal vestibule. It drops deep enough to physically touch the true vocal cords. Remember, the true vocal cords are the final physical barriers before the subglottis and trachea. However, look at the second part of the definition, which states that the material is successfully ejected. Because the food material touches this highly sensitive area, the patient's sensory alarm system is immediately triggered. Specifically, this is the superior laryngeal nerve branch of cranial nerve 10. The patient actively feels the invasion and produces a strong, effective cough. They manage to push the material completely back up and out of the airway. Because the material never passes below the vocal cords, this still falls under penetration category, not aspiration. It is absolutely not the more dangerous aspiration event. Then what is the exact clinical significance of this score? It tells us that the patient currently has moderate dysphagia, moderate swallowing dysfunction. The physical bulk of the tumor is likely preventing the larynx from closing completely during the swallow. But it also gives us a very positive and encouraging clinical finding. The patient's sensory nerve and their motor ability to clear the throat are still working. They can still actively feel and successfully protect their own airway. A score of 5 means material touches the folds but is not ejected. This indicates that tumor bulk is physically preventing complete glottic closure. This score means the food or liquid drops deep into the laryngeal vestibule. It drops deep enough to physically touch the true vocal cords. However, look at the final part of the definition, which states that material is not successfully ejected. The patient either fails to clear it out or they do not even try. Because the material does not drop below the vocal cords, this is still strictly defined as penetration, not aspiration. But this is a highly dangerous clinical situation for your patient. The leftover material is sitting directly on the final barrier to the airway. This score clearly indicates a moderate swallowing dysfunction. It tells us that the physical bulk of the tumor is likely preventing the larynx from closing completely during the swallow. While we might still consider saving the larynx, these patients are at extremely high risk for severe swallowing problems after radiation. Therefore, this specific patient requires intensive prophylactic swallowing therapy starting on the very first day of their treatment. However, organ preservation might still be possible for these patients. However, they are at very high risk for severe swallowing problems after radiation. Therefore, they require intensive prophylactic swallowing therapy starting on day 1. We need to really take care of these patients during the entire journey from day 1 of starting radiotherapy to the last day of radiation and during follow-up, long-term follow-up, even if they get cured. So we saw PAS score of 1 and 2 are good, 3, 4 and 5 means moderate dysfunction. Now let us move on to see score 6, 7 and 8. Here is the dangerous part. The score 6, 7 and 8 represents severe to catastrophic dysfunction of larynx. Let us first look at the score of 6. The score means dyed food or liquid completely breaches the true vocal cords. It drops deep into the subglottis or trachea. Because it passes below the vocal cords, this is definitely called aspiration. It is no longer a penetration, it is aspiration. However, the patient's sensory alarm is still working. They feel the material and trigger a strong, effective cough. They successfully push the material back up and out of the airway. Now let us examine a score of 7. Just like a score of 6, the material completely breaches the true vocal cord. It drops deep into the trachea. The patient's sensory nerves still detect this danger. They actively try to cough and clear their throat. But look closely at the definition. Despite their strong effort, the material is not successfully ejected. Once again, the material is not successfully ejected. It remains trapped inside the trachea. What is the clinical verdict for scores 6 and 7? Both scores indicate a severe mechanical and neurological impairment. The sensory alarm is still partially working because the patient is actively trying to cough, but their physical ability to protect the airway is severely failing. Because of this severe dysfunction, their suitability for chemoradiation must be strictly re-evaluated. Finally, look at score of 8. It is the absolute worst case scenario. The material drops completely below the vocal cords into the trachea. But look closely at the patient's response. Absolutely no effort is made to eject it. Absolutely no effort is made to eject it. The patient does not even try to cough. The dyed food simply pours directly into their lungs without triggering any protective reflex. This defines frank, silent aspiration. This specific score represents a functionally dead larynx. It confirms a catastrophic failure of the airway protection. The vital sensory alarm system controlled by cranial nerve 10th is completely destroyed. If you give high dose radiation to this patient, you will simply create a fibrotic, permanently open pipe from their mouth to the lungs. Therefore, a score of 8 is a strong, absolute indication for an upfront total laryngectomy. This slide explains why the exact same amount of tumor bulk can tell you completely different survival pathways. First, look at scores 6 and 7 on the scale. This side represents a purely mechanical failure. Here, the physical bulk of the tumor acts as a massive wedge blocking the epiglottis from folding back. However, Look closely at the neurology section just below it. The underlying neurology is 100% intact and cranial nerve 10 fires perfectly. The sensation remains fully active. The patient actively feels the food invasion and produces a strong protective cough. Because of this intact sensory loop, the functional prognosis is actually reversible. This is exactly why non-surgical organ preservation remains a viable option for them. Now compare this carefully to the right side of the screen, which represents a score of 8. This side represents a complete neurological failure. The cancer has completely destroyed the afferent sensory pathways. This creates a completely insensitive organ, resulting in catastrophic silent aspiration. Look at the prognosis for the score 8. Neural destruction caused by cancer is highly irreversible. It is irreversible. Our speech pathologists simply cannot rehabilitate a dead nerve. Therefore, the functional prognosis for a score of 8 is absolutely irreversible, and we must proceed with total laryngectomy instead of chemoradiation. This rehabilitation imperative. This slide breaks down the actual clinical outcomes driven by the landmark RTOG 9111 trial and our current NCCN and NISTRO guidelines. Look at the top blue pathway. This pathway represents patients with score of 6 and 7. When we apply chemoradiation to these patients, the tumor typically starts regressing by the 3rd week of treatment. As the tumor shrinks, the physical mechanical block simply melts away. Because their underlying motor and sensory nerves are still highly functional, their glottic competency is fully restored. This is exactly why organ preservation is officially permitted for those specific scores. However, there is a very clear distinct condition for this clinical success. You must manage these high-risk patients with extreme caution and active neurological support. Prophylactic swallowing therapy must begin on day 1 of their radiation. They must actively practice techniques like the effortful swallowing and the supraglottis swallow to protect their airway. Let me explain this again. Let us understand exactly what we mean by the rehabilitation imperative. It is the absolute non-negotiable rule for attempting to save a high-risk patient's larynx. When a patient has a score of 6 or 7 on the penetration aspiration scale, they are already experiencing severe swallowing dysfunction. However, because their vital sensory nerves are still active, they can sometimes choose non-surgical organ preservation using chemoradiation. But this choice comes with a very strict clinical condition. The patient must engage in intensive prophylactic swallowing therapy starting on the very first day of their radiation treatment. This is not an optional part of their care. They must actively practice techniques like effortful swallow or supraglottic swallow to retain their muscles and safely clear food. If we ignore this intensive rehabilitation, the patient is at an extremely high risk of permanent feeding tube dependence or fatal aspiration pneumonia. Therefore, in score 6 and 7 scenarios, saving the organ is only permitted if we also aggressively save the function. And remember, this imperative only applies to scores of 6 and 7, not 8. Now follow the bottom red pathway. This pathway represents a score of 8, which is silent aspiration. Larynx is profoundly dysfunctional here. If you apply chemoradiation here, you must remember that dead nerves cannot regenerate. The radiation will only leave behind a permanently open airway directly to the lungs. It creates a rigid fibrotic pipe. Extensive data from MD Anderson and the RTG trial confirm the fatal risk of this exact scenario. It is the ultimate predictor of permanent feeding tube dependence and fatal aspiration pneumonia. Therefore, you must never apply intensive concurrent chemoradiation to a profoundly dysfunctional larynx. For a patient with a score of 8, an upfront total laryngectomy is absolutely required to safely secure the airway and save their life. This slide shows a big problem in our daily practice in real world, especially in India. Western rules say we should try to save the voice box larynx for patients with a score of 6 or 7. But these rules assume everything is perfect and patient received ideal holistic care. They assume patients get uninterrupted care and always follow strict instructions. However, our local reality in India is very different. First, our patients often struggle with erratic compliance. Many do not come back for their long-term checkups. Second, we severely lack baseline diagnostics. Small peripheral hospitals often do not have dedicated speech and swallowing experts. Third, proper swallowing therapy is very hard to find. It is almost completely absent in rural areas during critical recovery times. Fourth, many of our patients outrightly refuse feeding tubes. They reject PEG or nasogastric tube before treatment starts. Keeping these tubes clear at home often causes severe infections and distress. What does all this mean for our patients? It means our patients with score of 6 and 7 are in great danger. They have a disproportionately high risk of getting fatal aspiration pneumonia. So what is my personal opinion here? I strongly advise all of you to offer these patients having score of 6 and 7 an upfront total laryngectomy and not radical chemoradiation. Choosing this definitive surgery is absolutely not a step backward. It is a much safer choice that fits our specific healthcare landscape. It gives our high-risk patient a highly predictable chance to survive. Let us summarize the specific advantages and limitations of the FEES procedure. Look at advantages first. First, we have direct anatomy. FEES provides high-definition direct visualization of the mucosal surface and the exact tumor topography. Second, it uniquely evaluates saliva and sensation. It is the only test that allows us to directly observe how a patient manages their own secretion. It also lets us physically test their vital sensory and motor responses before any food is given. Third, it involves absolutely zero radiation. Because there is no radiation exposure, we can test the patient using real food and we have no strict time limits. This also gives us the great advantage of using a real-time biofeedback during swallowing therapy. Finally, it offers absolute portability. We can easily perform this test directly at the patient's bedside or even in the intensive care unit. There are no strict weight limits or difficult positioning issues like we face in fluoroscopy suite. Now look at the strict limitations of this procedure. The most significant visual limitation is the whiteout period. At the exact 0.5 seconds when the swallowing is triggered, the base of the tongue retracts and the throat tissues squeeze tightly around the camera. This creates a brief transient blind spot where the screen goes completely white. Therefore, any aspiration that happens during that exact split second must be inferred from the aftermath. Second, there is a limited anatomical scope. FEES is strictly limited to observing the pharyngeal phase of swallowing. We simply cannot see the oral preparation phase or deeper esophageal space. Third, we must consider its invasive nature. Passing a flexible scope through the nasal passage can definitely cause discomfort for our patients. It also carries small risk of causing an epistaxis or triggering a vasovagal fainting episode. But overall, FEES is a very easy procedure. Patient tolerates it very well. It just takes 5 to 10 minutes. It is painless. There are hardly any complications. Finally, there is no volume quantification. Unlike a barium swallow, we cannot measure the exact millimeter volume of the aspirated material. You must also remember that the flexible scope requires a rigorous and time-consuming disinfection process between every single patient. This slide highlights a critical decision point for our multidisciplinary tumor board. There are these 3 absolute red flags for predicting chemoradiation failure. If you irradiate a functionally destroyed larynx with 70 gray of radiation, you are making a devastating clinical mistake. You will only create a rigid, non-compliant and fibrotic pipe directly to the patient's lung. This virtually guarantees that your patient will be permanently dependent on a tracheostomy and a feeding tube. Now let us examine these 3 distinct red flags one by one. Red flag number 1 is the silent aspiration of secretion. This tells us that the baseline motor and sensory alarm is completely destroyed by the tumor. This vital alarm is specifically controlled by cranial nerve 10. Remember our fundamental oncological rule. If a patient cannot safely manage their own natural saliva, they absolutely cannot manage real food. Red flag number 2 is the massive destruction of the epiglottis or pre-epiglottic space. The epiglottis is the primary mechanical shield that protects the airway during a swallow. Chemoradiation might successfully sterilize the cancer cells, but it will only leave behind an immobile, scarred stump. Because the primary shield is permanently eliminated, the airway remains continuously exposed to deadly aspiration. Red flag number 3 is the cricoarytenoid joint infiltration. In this specific scenario, the physical bulk of the tumor fixes the arytenoid cartilage in a completely open position. If you treat this fixed joint with high dose radiation, the severe tissue reaction will permanently fibrose this joint. It will remain permanently frozen in an abducted, completely unprotected position. What is the final clinical verdict for these 3 red flags? They represent absolute contraindication for non-surgical organ preservation. If you see any of these 3 signs during your endoscopic evaluation, the larynx is already functionally dead. An upfront total laryngectomy is strictly mandatory to safely secure the airway and save your patient's life. This slide brings all our endoscopic findings together into 2 distinct clinical pathways. First, let us look at pathway A, which represents the ideal candidate for non-surgical treatment. These patients typically have early T1 or T2 tumors. They might also have a low volume T3 tumors, but they must have absolutely no cartilage destruction. During their FEES procedure, their valvular and piriform sinuses are completely clear of secretions. When you test their sensation, they show a very strong and brisk laryngeal adductor reflex. Their mechanical swallowing test shows a perfect score of PS1 or PS2. What is the best treatment for them? Their larynx is structurally competent and their neurology is completely intact. You can confidently proceed with definitive concurrent chemoradiation. Now shift your focus to point pathway B, representing the high-risk candidate. These patients usually present with bulky T2 or T3 tumors. Their FEES exam shows a moderate pooling of frothy secretion in their throat. Their sensory reflex is blunted and their swallowing score falls anywhere between PS3 and 7. What does this specific profile tell us clinically? It means they have a severe mechanical obstruction blocking their pathway. However, their sensory protection and neural circuitry are still partially working. We can still choose non-surgical organ preservation for them, but you must proceed with extreme caution. This specific pathway strictly requires intensive prophylactic swallowing therapy starting on the very first day of radiation. They will also almost certainly need a temporary feeding tube to safely survive the peak mucositis phase of their radiation. This slide shows the details about the absolute contraindications for preservation. This pathway includes patients presenting with massive T4A tumors that have frankly destroyed the laryngeal cartilage. It also includes any patient who demonstrates catastrophic finding during their FEES procedure. Let us examine some specific endoscopic findings during FEES. First, you will see the frank, silent aspiration of the patient's own endogenous saliva. Second, when you test their sensory nerve function, the laryngeal adductor reflex will be absolutely absent. Third, their mechanical swallowing test will show a catastrophic score of 8 on the penetration aspiration scale. This means the dyed food bolus simply pours directly into their trachea. The patient makes absolutely no effort to cough or protect their airway. What is your verdict for such patients? What do these specific findings tell us? They confirm that the larynx is already functionally dead. It is dysfunctional. The primary mechanical shield has been destroyed by the tumor. More importantly, the vital sensory system is completely damaged. You must never offer non-surgical organ preservation to this specific patients. A upfront total laryngectomy is strictly mandatory. You should ideally combine this with a primary tracheoesophageal puncture or TEP to help restore their voice. This definitive surgery is the absolute only way to safely secure their airway and prevent a fatal aspiration pneumonia. This is perhaps the most important rule in modern laryngeal oncology. Anatomical resectability does not equal functional viability. Just because we can anatomically preserve an organ using chemoradiation does not mean that organ will actually work. Functional preservation is very different from anatomical preservation. If you save a larynx that cannot safely swallow or protect the airway, you have not truly helped your patient. A dysfunctional preserved larynx is a clinical liability, not a success. This is exactly why the FEES procedure is so absolutely critical to our decision making for whether to go for organ preservation strategy or upfront total laryngectomy. FEES provides the hard, objective data we need before we ever start treatment. We use this data to prevent fatal aspiration and avoid catastrophic radiation toxicity. Ultimately, it guides us to secure the safest and most predictable functional outcome for our patient. Now, while FEES is an incredible endoscopic tool, it is not our only option for evaluating the swallow. As we discussed earlier in the limitation slides, FEES has a major mechanical blind spot called the whiteout period. It is also strictly limited to the pharyngeal phase. This means we cannot evaluate the oral preparation phase or deeper esophageal phase. So what exactly do we do when we need a complete continuous view of entire esophageal process? We must shift our focus to our next major functional assessment tool. This brings us to the video fluoroscopic swallowing study, commonly known as VFSS. Many of you might also know this clinically as the modified barium swallow study. Unlike the endoscope, this tool uses real-time fluoroscopy to watch a barium-coated bolus move from the lips all the way down to the esophagus. Let us move to the next slide to explore exactly how this dynamic X-ray test works and when you should order it for your patient. How does VFSS compare to FEES for assessing aspiration? What are the common findings during a barium swallow? We have just finished our detailed discussion on FEES procedure. While FEES is a fantastic tool, you must remember it has some strict limitations. It is a major mechanical blind spot called the whiteout period. It also strictly limited to seeing only the pharyngeal phase. This means we cannot evaluate the oral preparation phase or the deeper esophageal phase. So what exactly do we do when we need a complete continuous view of the entire swallowing process? We must shift our focus to our next major diagnostic tool, video fluoroscopic swallowing study or VFSS. Video fluoroscopic swallowing study or VFSS. Many of you might also know this clinically as the modified barium swallow study. Modified barium swallow study. You must have been hearing usual barium swallow study from your MBBS time, which was a traditional standard barium swallow test. Modified barium swallow study is called modified because a traditional standard barium swallow is specifically adapted to evaluate the functional mechanics of eating and drinking. Unlike the flexible endoscope in FEES procedure, this tool uses real-time X-ray or fluoroscopy. It allows us to watch a barium-coated bolus move from the lips all the way down into the esophagus. There is no whiteout period, so our view is completely continuous. We will look at how this test evaluates airway protection and directly guides our decision for organ preservation. We will discuss the non-negotiable technical standards that you must demand from your radiology team. We will also review standards, radiation safety, and dismiss some very common myths. Finally, we will combine all this knowledge to compare VFSS and FEES. This will help you understand exactly when you should order which test for your head and neck cancer patients. Let us begin. Let us see exactly how VFSS maps the swallow. VFSS is much more than a simple aspiration test. It is not just a pass or fail check to see if food enters the lung. It is a live, dynamic video that shows exactly how all the muscles work together. It lets us evaluate the entire swallowing process across 3 distinct phases. First is the oral phase. Here we watch exactly how the patient prepares food in their mouth. We look closely at their lip closure, tongue control and palatal movement. Why is this specific phase important for us in oncology? Because an oral cavity tumor can completely destroy how the mouth moves food. Severe jaw stiffness from radiation can also block this entire process. Second is the critical pharyngeal phase. This phase is where the actual protection of the airway happens. We use a continuous X-ray video to watch the exact movements. This allows us to see exactly how high your voice box lifts during a swallow. We also watch the epiglottis fold over to safely seal the airway. Remember our earlier discussions on tumor interference. A bulky T3 or T4 tumors will physically block this vital upward movement of larynx while swallowing. Third is the esophageal phase. Unlike the flexible fees procedure, VFSS lets us look directly at the esophagus also. We can clearly see how food moves down and clears the sphincter muscle. This view is absolutely vital for our head and neck cancer patients. Radiation scarring often causes late strictures and severe muscle spasms in this exact area. If your patient complains that food is getting stuck in their chest, this specific view gives you the exact diagnosis. Let us move to the next slide to break down these three phases into 15 specific physiological components. We need to break down these three main phases into 15 specific components. This is the exact checklist you must use when reviewing a VFSS video. Look at the oral phase first, which has 5 distinct steps. It starts from simple lip closure and ends with active bolus transport. If your patient has an oral cavity tumor or restricted jaw opening, this entire transport system can fail. Now look at pharyngeal phase, which comprises of steps 6 to 14. This is the most complex and critical part of the entire swallow. It involves vital mechanical actions like anterior hyoid excursion and epiglottic inversion. These are the precise movements required to tightly seal and protect the airway. As we discussed earlier, a bulky laryngeal tumor will physically freeze these vital movements. Finally, we have esophageal phase, which focuses entirely on component 15. This is simply the evaluation of esophageal clearance. We must ensure the food completely clears the chest and enters the stomach. Therefore, severe radiation fibrosis can cause dangerous strictures in this exact area. By carefully evaluating all 15 components, you get a complete objective map of the patient's swallowing function. These are non-negotiable technical standards you must follow for every VFSS procedure. One is with regard to how frequently you take X-ray per second, called pulses per second. The other is regarding the oral contrast you will give to the patient. There should be 30 pulses per second. You must ensure the X-ray video runs continuously at this exact speed. Sometimes a radiology department might suggest using a slower rate like 15 pulses per second to save radiation. You must strictly refuse this compromise. A slower video will cause you to completely miss rapid episodes of microaspiration. Missing this vital information directly alters your final treatment recommendations. Now look at the strict contrast standardization. You must insist on using standard factory produced barium sulfate. Do not let your team mix raw barium powder with regular hospital food. This off-label mixing creates an unpredictable viscosity. An unpredictable thickness completely invalidates your swallowing results. Furthermore, there is a critical safety issue here. If a patient accidentally inhales pure barium, it is relatively inert and safe for their lungs. But if they inhale an off-label mixture of barium and real food, it can trigger a severe and fatal pneumonia. Let us move on to discuss radiation safety issue when we do VFSS. Many clinicians are unnecessarily afraid of X-ray exposure during a VFSS. Because of these unfounded fears, they often skip important part of the test. VFS is an exceptionally low dose examination. Look at this comparison. The average adult exposure during this test is only 0.27 millisievert. This is actually less radiation than a standard screening mammogram done once in a year. The stochastic risk of getting cancer from this test is exceptionally low. For example, it is only 0.0032% for a 20-year-old female. Therefore, you must never omit a clinically indicated sequence just to save a negligible amount of radiation. Also, we must strictly follow the ALARA principle. ALARA means as low as reasonably achievable. First is the time. You should minimize your fluoroscopy time, but never at the cost of diagnostic accuracy. Second is distance. If you simply double your distance from the X-ray tube, you reduce your exposure by 4 times. Just taking one single step back makes a massive difference for your own safety. Third is shielding. The use of lead aprons, thyroid shields, and dosimetry badges is absolutely mandatory for everyone in the room. There are 2 main enemies of laryngeal function. First is the tumor interference. A bulky T3 or T4 tumor physically blocks the normal swallowing mechanics. It acts like a massive mechanical wedge in the patient's throat. It mechanically blocks the vital upward movement of the larynx. Because the larynx cannot lift, it completely prevents the epiglottis from folding over. This leaves the airway completely exposed and unprotected during a swallow. The second enemy is the radiation-induced fibrosis. These are the severe tissue changes that happen months or year after chemoradiation. The intense radiation essentially scars and tethers the entire hyoid and larynx complex. It leaves the patient with stiff, immobile, and completely frozen throat structures. It also causes dangerous late onset strictures and severe cricopharyngeal muscle spasms. Both of these conditions can completely destroy a patient's ability to swallow safely. You must use our functional tests to completely identify and manage both of these distinct clinical scenarios. This slide brings together exactly how we use the penetration aspiration scale to choose between organ preservation and surgery. We have already discussed these exact clinical pathways in great detail during our earlier feast discussion. Therefore, we will not go into deep details again right now. Let us just do a very quick and practical recap of these 4 distinct pathways. Score of 1 and 2 indicate a completely functional larynx. These patients are excellent, ideal candidate for definitive radiation and chemoradiation. Score of 3, 4 and 5 represent airway penetration. These patients are still solid candidates for chemoradiation. However, they will require active swallowing therapy and careful monitoring throughout their treatment. Score of 6 and 7 represents strict mechanical failure. The physical bulk of the tumor holds the airway open, but their vital superior laryngeal nerve is still intact, meaning they can still feel the food and cough. These patients remain candidate for chemoradiation, but they are at very high risk. Remember our strict rule for this specific group. They absolutely require intensive prophylactic swallowing therapy starting from day 1. A score of 8 or silent aspiration represents a catastrophic neurological failure. The tumor has irreversibly destroyed the vital sensory nerves. Treating this specific larynx with radiation will only leave a rigid, permanently open pipe directly to the lungs. Therefore, non-surgical organ preservation is absolutely contraindicated. An upfront total laryngectomy is strictly mandated to safely secure the airway and save the patient's life. This slide brings together exactly how we use penetration scale to choose between organ preservation and surgery. We have already discussed these exact clinical pathways in great details during our earlier fees discussion. Therefore, we will not go into deep detail again. Now I am going to play a series of 8 short clinical videos. I am going to show you exactly what the penetration aspiration scale looks like in real time. You will see the actual video fluoroscopic swallowing study or VFSS. We will start with a perfectly normal swallow and move all the way down to catastrophic failure of score 8. Please watch the first video for score 1. Notice how the dark contrast material passes cleanly into the esophagus. Absolutely nothing enters the airway. This represents a structurally and neurologically perfect larynx. This patient is an ideal candidate for non-surgical organ preservation. Now watch score 2. You will see a tiny flash of material enter the laryngeal vestibule. But look closely. It remains strictly above the true vocal cords. More importantly, the patient instantly and successfully ejects it back out. This is still considered a highly functional and safe swallow. Now watch score 3. Here you see the material penetrates the airway and sit above the vocal cord. But notice the critical difference here. The material is not ejected. This shows moderate mechanical dysfunction, meaning the tumor bulk is likely preventing complete airway closure. Now watch score 4. This is a much deeper penetration. Watch the material physically drop down and contact the true vocal cords. But the sensory alarm fires perfectly and the patient successfully ejects it. Now look at score 5. Once again, the material drops down and contacts the true vocal cords, but this time it is not ejected. This patient is at very high risk of severe dysphagia if we subject them to radiation. Let us move into the severe danger zone of score 6. Watch the material completely breach the vocal cords and fall into the trachea. This is true aspiration. But look at the patient's immediate physiological response. They instantly trigger a strong cough and successfully ejects the material back out of the airway. This proves that their cranial nerve 10 is still completely intact. Now watch score 7. The material falls deep below the vocal cords into the trachea. The patient senses the invasion and tries very hard to cough it out. But the mechanical obstruction from the tumor is simply too severe. The aspirated material remains trapped in the trachea despite their intense coughing effort. Remember, score 6 and 7 represents a severe mechanical failure, but the organ can still potentially be rehabilitated with aggressive therapy. Finally, prepare yourself for the 8th videos showing score 8. Watch the liquid pours directly through the vocal cord and deep into the lungs. Notice the absolute and terrifying lack of response. The patient does not cough, choke, or make any effort whatsoever to clear the airway. This is catastrophic silent aspiration. The cancer has completely destroyed the afferent sensory pathway. This larynx is functionally dead, and an upfront total laryngectomy is absolutely mandatory to save their life. This is another case of score 8 showing how the liquid pours directly through the vocal cords and deep into the lungs. The patient does not cough, choke, or make any effort to clear the airways. This is dangerous silent aspiration. This larynx is functionally dead. An upfront total laryngectomy is absolutely mandatory. So you saw how VFSS beautifully shows you penetration and aspiration. Now that we have studied both FEES earlier and VFSS now, let us compare them. We have two incredibly powerful diagnostic tools, but you must understand that they are complementary modalities. They are absolutely not mutually exclusive, and they are not competing against each other. Look at VFSS, or the modified barium swallow. I like to call this our biomechanical radiologic workhorse. It gives us a continuous real-time visualization of the entire swallowing sequence from mouth to the stomach. Because it uses X-ray, there is absolutely no whiteout period to blind our view. Now look at FEES, our flexible endoscopic tool. This is our highly portable option that gives us a direct, high-definition mucosal view. It allows us to physically see the exact tumor topography, secretion pooling, and directly test tissue sensation. So now the question is, should you routinely order both tests together for every single patient? Absolutely not. Doing both tests is exhausting for a cancer patient and waste vital healthcare resources. You must be smart and choose the specific tool that answers your specific clinical question. Let us move to the next slide to compare their exact diagnostic capabilities side by side. Let us compare them with regard to their diagnostic capabilities matrix. It compares our two main tools side by side. You must know exactly what each test can and cannot do. Look at the first two rows. With VFSS, we use an X-ray to get a lateral and anterior posterior view. Because it is an X-ray, there is absolutely no whiteout effect. You get a completely continuous, uninterrupted video of the entire swallow. With FEES, we look straight down from the top using a camera. But remember, the camera gets completely blocked by the throat muscles during the actual swallow. Now look at the third row for the esophageal phase. This is a major advantage for the fluoroscopic test. VFSS allows us to clearly visualize the transit and clearance of food into the chest. The FEES camera simply cannot see anything below the true vocal cord. Now look at the fourth row. Here, FEES is the absolute winner. It gives us an excellent direct assessment of how the patient handles their own endogenous saliva. VFSS is very poor at visualizing these natural secretions. Finally, look at the last two rows. FEES exposes the patient to absolutely zero radiation. More importantly, it allows us to perform direct physical tissue testing. We can literally touch the voice box with the camera to physically test the sensory nerves. With VFSS, we can only infer or guess the sensory function based on whether the patient coughs. By understanding this simple comparison, you will always know exactly which test to order for your patient. This slide tells us exactly when we should choose to order FEES as our very first test. Look at the first point. Secretion management. Only the flexible endoscope can clearly show us how a patient handles their natural saliva. It perfectly reveals if a patient is silently aspirating their own endogenous saliva. Remember, the barium X-ray is very poor at showing us these natural secretions. Second point, direct sensory testing. FEES allows us to physically touch the pharyngeal mucosa with the camera tip. This is the only accurate way to directly test the laryngeal adductor reflex, which is controlled by cranial nerve 10. Third point, this covers mucosal topography. FEES gives us a direct high-definition visual of the actual tissues. We can clearly see the exact tumor bulk, severe radiation mucositis, and any structural vocal cord fixation. Finally, fourth point, logistical barriers. The FEES equipment is completely portable. It is absolutely ideal for our critical oncology patients who are in their intensive care unit or on ventilators. It is the perfect choice for patients who are simply too weak to be safely transported to a radiology suite. By mastering these four specific points, you will always know when FEES is your best starting tool. Now let us look at the exact opposite scenario. This slide tells us exactly when we must strictly order a VFSS as our very first test. Look at the very first point in red at the top. Esophageal dysfunction. Remember, the flexible FEES camera cannot see anything below the true vocal cords. If your patient complains that food is sticking in their lower neck or chest, you must order a VFSS. It is the only way to accurately diagnose a stricture or muscle spasm caused by radiation. Second point, severe trismus and the oral phase. Sometimes a patient has a massive oral cavity tumor or severe jaw stiffness. This severe restriction makes passing a flexible endoscope physically impossible or very painful. In these specific cases, VFSS is absolutely mandatory. It allows us to safely visualize exactly how the mouth prepares and transports the food. Final point, quantifying biomechanics. FEES only gives us a top-down view of the throat, but VFSS gives us a clear continuous X-ray from the side. This is the only accurate way to measure the exact degree of hyolaryngeal elevation. It helps us clearly see if the voice box is tethered down by the dense radiation scarring. By understanding these specific indications, you will never waste your time ordering the wrong test for your cancer patients. Let us look at a very practical clinical concept called targeted sequential testing. Please remember this golden rule for your daily practice. You must never order both of these tests simultaneously on a routine basis. Our head and neck cancer patient already suffer from severe pain, trismus and extreme fatigue. Subjecting them to two intensive procedures back to back is exhausting and wastes vital healthcare resources. You should combine them only to solve a very specific anatomical blind spot. Imagine you have just performed a FEES procedure as your first step. During the test, you observe a massive pooling of secretion in the patient's piriform sinuses. Even after asking the patient to swallow multiple times, this pooling simply does not clear. Remember that your flexible endoscope is completely blind below the true vocal cords. Therefore, FEES cannot explain exactly why the upper esophageal sphincter is failing to open. It is exactly when you must move to VFSS. This specific blind spot is the exact indication to order a VFSS as step 2. You need this continuous X-ray view to look deeper into the lower neck. VFSS will clearly differentiate between two very distinct physiological problems. It will show if the failure is simply a lack of upward hyolaryngeal traction preventing the sphincter from pulling open, or it will definitely prove if there is a dense fibrotic cricopharyngeal stricture caused by previous radiation. By using this smart targeted approach, you get the exact diagnosis while minimizing the physical burden on your cancer patient. This is a critical need for global standards and collaboration. You might be surprised to know a very concerning fact. A recent systematic review showed that most current global guidelines for VFSS actually lack standard multidisciplinary input. Many existing guidelines take a completely uniprofessional approach and omit the vital roles of radiographers. But in our head and neck oncology practice, this test absolutely requires a coordinated team efforts. Look at the 3 pillars on your screen. First, on the left, we have radiologist and radiographer. They are directly responsible for the technical quality and the safety of the entire procedure. They must ensure we get that mandatory continuous X-ray video at exactly 30 pulses per second. We also strictly enforce patient positioning and all ALARA radiation safety protocols. Look at the second pillar. This represents the speech language pathologist or SLP. Their job is to safely administer the standardized barium consistencies. They actively guide the patient through the specific compensatory maneuvers during the live test. This helps them identify the exact physiological targets for post-radiation swelling rehabilitation. Finally, look at the third pillar. This represents you, the oncologist. Your crucial role is to take all this complex biomechanical data and translate it into a definitive cancer treatment pathway. You must use this precise functional data to make that high-stake decision between organ preservation and an upfront total laryngectomy. Without this strict multidisciplinary teamwork, we simply cannot provide the safest care for our complex cancer patients. This is your ultimate clinical checklist. It brings together all the core rules we have discussed today. You must keep these 5 golden rules in mind for your daily practice. You must always demand 30 pulses per second for your X-ray video. Never compromise your diagnostic accuracy just to save a negligible amount of radiation. You must strictly banish off-label barium mixing in your clinic. Insist that your team uses only standardized factory-produced consistencies. You must evaluate the entire swelling mechanism. Ensure your views are perfectly capture the oral, pharyngeal and esophageal phases. You must accurately translate the penetration aspiration scale into definitive action. Always remember that a score of 8 means catastrophic silent aspiration. This severe neurological failure strictly mandates an upfront total laryngectomy. You must choose your diagnostic modality wisely. Order a FEES when you need to evaluate natural secretions or directly see the mucosa. But you must order a VFSS when you suspect esophageal stricture or need to map the exact biomechanics. By following this strict checklist, you will always provide the safest care for your head and neck cancer patient. Guys, with this we have finished our discussion on assessment of laryngeal function in great details. So with this we finish our discussion on two extremely and commonly used tools for assessment of laryngeal function. Next two tools we have are video stroboscopy and high definition laryngoscopy with narrow band imaging. Please look at these two specialized tools on your screen. These are video stroboscopy and high definition narrow band imaging or NBI. I will also discuss those tools again when you see my next video lecture on the management of early laryngeal cancer. For now, I want you to understand their specific role in our baseline functional assessment. These tools do not dictate overall airway safety for radical chemoradiation like FEES and VFSS do. Instead, they are absolutely critical for objective glottic and mucosal assessment. Look at video stroboscopy on the left side of your screen. This tool uses synchronized flashing light to create a slow motion optical illusion of vocal cord vibration. It allows us to evaluate the mucosal wave dynamically. This helps us detect early T1 microinvasion which presents as a focal tethering of the mucosal wave. We use this pure vibratory data specifically to predict future post-treatment voice quality. I have already covered video stroboscopy in my previous video on OPD-based evaluation of laryngeal and hypopharyngeal cancer. So we will not be covering it now. What I am going to show you is two videos of video stroboscopy. First, a completely normal larynx, and second, having an early glottic cancer. Let us look at a video showing how an actual stroboscopy looks like in a normal person. In a few moments, you are going to watch a beautiful high definition demonstration of an actual video stroboscopy on a normal patient. Before I hit play, I want you to understand exactly what you are looking at and why it is so critical. Human vocal cords are incredibly tiny resonating muscles. During a normal conversation, these tiny muscles vibrate incredibly fast, firing between 120 to 240 times per second. The naked human eye simply cannot track that speed of vocal cords. This is exactly why we used video stroboscopy, which works just like slow motion photography. By using a synchronized flashing light, it creates an optical illusion that allows us to clearly evaluate the individual mucosal wave. As you watch this 2 minutes video, I want you to listen very closely to the speech pathologist's instruction. She does not just ask the patient to make a single quiet sound. She actively commands the patient to change their pitch to get much louder and to belt out the sound from their chest. She is intentionally stress testing the vocal cords under different aerodynamic pressure. If this were an early T1 laryngeal cancer, these aggressive dynamic pitch changes would instantly reveal the focal tethering where the microtumor has invaded the underlying ligament. But in this normal patient, you will see a perfectly fluid, symmetrical mucosal wave. Please watch the video of approximately 2 minutes duration now.
Try and clear that up.
Notice the beautiful, smooth,
Your voice comes
rippling
from tiny
effect
resonating
traveling
muscles
across the
called vocal
tissue.
cords. They're about the size of a dime
This is the
in a
highly
woman
critical
and about the size
mucosal
of a
wave.
nickel in a man.
You are literally watching
Your
the
vocal
loose
cords vibrate
superficial
very
mucosal
quickly,
layer
120 to
sliding
240
freely
times
over
per
the
second in
deeper,
conversation.
stiffer
Human eye can't
vocal
track
ligaments
that.
and muscles.
Video stroboscopy works
Look at
like slow
how
motion
both vocal
photography.
cords move
It allows
symmetrically and
us to
fluidly.
look at the vocal
They
cords
meet
while they're
perfectly in the
vibrating
midline to
and
create
find
a
ways to help
tight
them move
glottic
normally
seal.
again. When your
There is
vocal cords
absolutely
move
no
normally, you have a
stiffness
clear voice.
and no tetherness of the superficial tissue. If an early microscopic squamous cell carcinoma was hiding here, it would act like a rigid, deep anchor. It would focally dampen or completely destroy the smooth mucosal wave long before the entire cord becomes fixed. But in this video, the mucosal pliability is completely healthy and normal. You have just seen what a perfectly healthy mucosal fluid mucosal wave looks like. Now I am going to play a video of a patient presenting with a highly suspicious ulcerated glottic lesion. This patient has irregular ulcerated lesion at the free edge of the anterior half of the affected vocal cord. You will see a distinct irregularity extending all the way down to the anterior commissure. Remember, these tiny muscles are vibrating between 120 to 240 times per second. Your naked eyes could never track this rapid movement to see the true depth of the disease. But with the slow motion optical illusion of video stroboscopy, the functional damage becomes instantly obvious. As the video plays, I want you to actively compare the two vocal cords. The opposite healthy vocal cords continues to move beautifully, maintaining a normal rippling mucosal wave. But look at the lesion on the affected side. The mucosal wave is completely missing. This is an absolute clinical red flag for early invasive laryngeal cancer. This complete loss of vibration proves that the tumor is not just sitting on the superficial epithelium. It proves that the cancer has deeply invaded and tethered the underlying vocal ligament. This rigid, stiff segment is exactly how we use this dynamic tool to predict the depth of invasion before you ever make a surgical decision. Please watch this abnormal video now.
Big breath.
Next tool we have is high definition narrowband imaging tool. Narrowband imaging uses specific optical filtering to dramatically enhance mucosal contrast. It identifies the abnormal neoangiogenic intraepithelial capillary loop patterns. We refer to these as IPCL patterns. This helps us perfectly map the exact margins of the superficial disease spread. This precise topographic mapping dictates whether organ-sparing treatment like transoral laser microsurgery are actually viable for your patient. I have already covered video stroboscopy in my previous video on OPD-based evaluation of laryngeal and hypopharyngeal cancer, so will not be covering it now. So with this, we finish our discussion on video stroboscopy and narrowband imaging tools. Next in the list we have is nutritional screening. We have just finished discussing our highly advanced instrumental tools. We now know exactly how to objectively assess the swelling biomechanics of a cancerous larynx or hypopharynx. But knowing the anatomy is only half the battle. If your patient does not have the physiological reserve to actually survive this difficult treatment, all of that beautiful imaging is completely useless. This brings us to the next critical step in our baseline functional assessment, nutritional screening. Let us talk about nutrition. Many residents think nutrition is only dietitian's job. You're absolutely wrong. As a treating oncologist, you must take total ownership of your patient's baseline nutrition. Of course, you will take help from your dietitian, but you cannot simply outsource this responsibility to another department. This slide shows the brutal reality of malnutrition in our head and neck cancer patients. First, look at the baseline threat. Laryngeal and hypopharyngeal cancers badly affect a patient's mechanical ability to swallow. These bulky tumors trigger severe pain and cause rapid early weight loss long before you even start your treatment. Second, you have the treatment toll. When you subject this vulnerable patient to 7 weeks of radical chemoradiation, you guarantee severe mucositis. Normal swallowing will become very difficult, sometimes impossible. Third, there is a breaking point. If your patient starts their treatment course already malnourished, they do not have the physiological reserve to survive. They will predictably crash by third week of treatment. Let us move to the next slide to exactly understand what happens to your treatment plan when they hit this dangerous breaking point. Let us trace exactly what happens when your patient hits that nutritional breaking point. Look at the left side of your chart first. If they suffer from significant weight loss, their immobilization mask will become very loose. Why is this a big problem? Because your highly precise radiation beam will completely miss the tumor target and hit the normal organs. Now look at the right side of the chart. When they suffer a severe malnutritional crash by the third week, they simply cannot tolerate the tough treatment. They will be forced to skip their chemotherapy cycles. They will miss their scheduled radiation fractions. This results in a dangerous treatment break. Both of these failures lead directly to a big problem: tumor repopulation. You must remember this absolute rule of radiobiology. Any treatment break allows the tumor to rapidly repopulate. If your patient misses days of treatment, your entire treatment plan will fail. This is exactly why you must establish a strict, objective nutritional baseline before day 1. Let us move to the next slide to see exactly how we measure this baseline using objective tools. We do not just guess. We use validated objective scoring tools. The first tool is the Malnutrition Universal Screening Tool, or MUST. MUST is a very fast and simple screening test. It uses exactly 3 clinical parameters. First, it calculates the patient's current body mass index, or BMI. Second, it calculates the percentage of unplanned weight loss over the last 3 to 6 months. Third, it evaluates the acute disease effect. It simply asks if the patient has been unable to eat for more than 5 days. You add these individual scores together to get a final number. A score of 2 or more indicates that your patient is at a very high risk of malnutrition. MUST is an excellent tool for rapid general screening in a busy OPD. But for head and neck cancer oncology, it is often not enough. The complexities of our cancer patient require something much deeper. Let us move to the next slide to see our true gold standard tool. This is the patient-generated subjective global assessment or PGSGA. If you are ever asked in an exam for the absolute gold standard nutritional tool in oncology, this is your answer. The PGSGA is specifically designed for our cancer patient. It does not just look at simple weight measurement. It looks at the exact reasons why your patient cannot eat. This tool is divided into two distinct sections. The first section is the patient-generated input. They report their exact weight history and their precise food intake. But most importantly, they engage in active symptom tracking. They specifically check boxes for pain, dry mouth, nausea, and swallowing difficulty. The second section is the clinician assessment. This section is completed entirely by you. You must evaluate their metabolic stress yourself. You must perform a physical exam to actively detect any fat and muscle wasting. When you combine these two inputs, the PGSGA generates a final numerical score. It categorizes your patient into a final stage of A, B, or C. Stage C is a massive clinical alarm. It indicates severe malnutrition. If your patient is in stage C, you must intervene before you even think about starting radical radiation. Let us move to the next slide to directly compare these two nutritional tools so you know exactly when to use them. Look at the comparison between MUST score and PGSGA score. Look at MUST score first. This tool is strictly for rapid general screening in your busy OPD or wards. It takes less than 5 minutes to complete. It only looks at basic parameters like BMI and recent weight loss. More importantly, it has absolutely zero symptom tracking. Now look at the PGSGA. This is your detailed, definitive nutritional assessment specifically for cancer patients. It takes 10 to 15 minutes to complete, but it provides very good clinical value. It tracks complex parameters like metabolic demand, precise food intake, and physical muscle wasting. Crucially, it actively tracks the exact symptoms affecting your patient's ability to eat. It strictly records their pain, severe dysphagia, dry mouth, and nausea. The MUST score is only good for initial identification of a problem, but the PGSGA is excellent for guiding your specific dietary and medical interventions. Let us move on to the next slide to understand exactly how we use these scores to make a life-saving clinical decision. Why exactly do we calculate these detailed nutritional scores? We do it to make one critical life-saving decision. We need to decide if we should place a prophylactic feeding tube before starting any radiation treatment. Listen to me very carefully. Do not wait for the patient to stop eating in the middle of their treatment. Placing a feeding tube in an irradiated, swollen throat is extremely difficult and highly morbid. Cooperation from patient is very poor when radiation is halfway through. According to major oncology guidelines, you must place a prophylactic PEG or RILES tube in specific high-risk scenario. First, if your patient has a high PGSGA score showing severe baseline malnutrition, you place the tube. Second, if the patient has lost more than 10% of their total body weight, you place the tube. Third, if the patient has a bulky T3 or T4 hypopharyngeal tumor that completely blocks the airway, you place the tube. You must secure their nutrition first. Only then can you aggressively deliver your radical chemoradiation without any dangerous interruptions. This completes our comprehensive baseline functional assessment ensuring your patient is fully prepared for treatment. Our next tool for baseline functional assessment is pulmonary function test and peak flow evaluation. We have successfully secured our patient's nutritional baseline. Now we must move to the final piece of our functional assessment. We are going to discuss pulmonary function test and peak cough flow. Many young oncologists focus entirely on the tumor in the throat and completely forget about the chest. This is a fatal clinical error. You cannot separate upper airways from the lower airways in your treatment planning. If you treat the throat without testing the lungs, your patient might not survive the consequences. Let us understand exactly how the larynx and lungs are permanently connected. Many young oncologist residents think the larynx is simply a tool for speaking. This is a very dangerous misunderstanding. Its primary job is actually to protect the lung. It acts as a vital biological sphincter. When we treat these cancers with radical chemoradiation, we directly damage this critical sphincter. The heavy radiation dose causes severe edema, permanent fibrosis, and deep sensory neuropathy. Your patient will aspirate after this intense treatment. This is an absolute certainty. But remember this critical point. Aspiration only kills the patient if they cannot cough it out. If your patient has lungs completely destroyed by 30 or 40 years of heavy smoking, they will simply die from a massive aspiration pneumonia. This is the exact reason why you must test the lungs before you even think about treating their cancer. You cannot separate the upper airway from the lower airway in your treatment plan. Let us move on to see exactly how we measure this vital lung capacity. You must order a baseline pulmonary function test. We are looking specifically at spirometry. Almost all of your head and neck cancer patients are heavy tobacco users. They will have baseline chronic obstructive pulmonary disease or COPD. You need to know the exact severity of their COPD before day 1. You must evaluate the forced expiratory volume in 1 second or FEV1. If the FEV1 is severely compromised at less than 50% of predicted, the patient has zero physiological reserve. When the severe radiation mucositis hits, they will definitely microaspirate their own saliva. Their compromised lungs will completely fail. You cannot safely offer organ preservation to a patient who has no pulmonary reserve. Look at the next measurement tool on your screen, spirometry. Spirometry tells you overall lung capacity. But you also need a mechanical test. This is the peak cough flow or PCF. Peak cough flow tells you the mechanical expulsive power. It measures how fast the patient can push air out during a strong voluntary cough. This is the exact physical mechanism required to clear aspirated food or fluids from the airway. It is a direct functional surrogate for airway safety. A normal peak cough flow is over 400 liters per minute. If your patient has a peak cough flow of less than 160 liters per minute, they are in massive danger. They simply do not have the physical strength to clear their airway. They are at extremely high risk of a fatal aspiration pneumonia. Let us compare these two tools. Look at the left column for pulmonary function test. PFT grades the severity of baseline COPD and airflow obstruction. Its oncologic focus is to measure the overall physiological reserve for treatment tolerance. The danger threshold is severe restriction with an FEV1 even of less than 50%. Now look at the right column for peak cough flow. PCF grades the direct mechanical ability to clear the airway. Its oncologic focus is a direct risk assessment for fatal aspiration pneumonia. The absolute danger threshold here is less than 160 liters per second. Let us move on to the final slide to see how we use these two tools to make our most difficult decision. Please look at this flowchart on your final slide. Why do we do these rigorous pulmonary tests? We do them to make the most critical decision in head and neck oncology. Imagine you have a patient with a bulky T3 laryngeal or hypopharyngeal cancer. You might naturally want to offer them radical chemoradiation for organ preservation. But you must look at their lungs first. If the PFT shows severe COPD and the peak cough flow is extremely weak, you must stop. Organ preservation is strictly contraindicated here. If you deliver 70 grade to this patient, you will condemn their damaged lungs to recurrent fatal pneumonia. In this exact scenario, you must perform an upfront total laryngectomy. A total laryngectomy permanently separates the airway from the digestive tract. It protects their weak lungs from aspiration forever. It is not that total laryngectomy is easy to do in these patients with damaged lung. It will be difficult, especially for anesthesia and post-recovery point of view. But remember what I told you at the beginning of my lecture. Living with a permanent laryngectomy stoma is far better than living with an anatomically intact but completely dysfunctional larynx. You must sacrifice the voice box to save the life. This is exactly how you use functional baseline tests to make strict guideline-driven clinical decisions. With this, we have completed discussion on our 8th tool for baseline functional assessment. Let us now move on to our final 9th and 10th tool, patient-reported outcome measures. We now move to the next final piece of our work. This is the integration of patient-reported outcome measures or PROMs. You cannot rely solely on your objective scans and endoscopes. A CT scan beautifully maps the anatomy, but it completely fails to map the human cost. If you ignore the patient's subjective experience, you are failing in your clinical duty. Please look at the timeline on your screen. Radical chemoradiation causes massive collateral damage. If your patient complains of a severe dysphagia at month 6, how do you know the exact cause? Was it the radiation or was their swallowing already destroyed by the tumor on day 1? You cannot accurately grade post-treatment toxicity without a documented pre-treatment baseline. Here comes the role of patient-reported outcomes measures, PROMs. PROM are not optional survey. They are strictly validated mandatory clinical instrument. You must establish this subjective baseline before you start any treatment. There are many tools available for PROM. Look at our first tool on the screen. This is the EAT-10. It is your rapid triage tool for symptom severity. A score of 3 or higher is strictly abnormal. This must trigger an immediate referral to your speech pathologist. This is the MD-ADI or MD Anderson Dysphagia Inventory. This is the premier tool for evaluating the true impact of dysphagia. Look at the triangle on the left side of your slide. The MD-ADI does not just measure basic physical symptoms like the EAT-10 does. It actively evaluates the emotional, functional, and physical burden of swallowing difficulty. It directly measures their true quality of life. It tells you if the patient is too embarrassed to eat with their own family. It tells you if they are completely isolating themselves because they choke during every meal. You must understand this deep psychological burden before you plan your treatment. This is VHI 10. Laryngeal cancer absolutely destroys the voice. You must document this baseline vocal impairment before offering organ preservation. A preserved larynx is totally useless if the voice handicap remains devastating. This is the EOTC Head and Neck 35 module. This stands for the European Organization for Research and Treatment of Cancer. It is a highly comprehensive 35 item questionnaire. It is built specifically for our head and neck cancer patients. Look at the red zones marked on the human figure on your slide. This tool evaluates a very broad spectrum of baseline symptoms. It establishes your exact baseline for pain, dry mouth, sticky saliva, and severe coughing. It also measures the exact level of their social eating impairment. You must map all of these specific symptoms before your radiation makes them worse. Look at the comparison between these four tools. You must understand the distinct clinical focus of each tool. EAT 10 is strictly for rapid symptom triage. MD-ADI and VHI 10 measure the exact quality of life burden. We now come to the most critical part of the entire process. How do you actually use all of this subjective data? You do not just file these questionnaires away in the patient chart. You must integrate this data directly into your patient management protocol. You must combine your objective data like your scans and fees with your subjective baseline PROMs. This creates a complete holistic picture of the patient's actual suffering. Imagine your patient has an early T2 clotic cancer. Your scan might tell you the tumor is very small and highly curable. But if their baseline VHI 10 score is catastrophically high, you know their functional impairment is already severe. The tumor is already destroying their daily quality of life. Imagine a patient with hypopharyngeal cancer. If they score terribly on their baseline MD-ADI and EAT 10 questionnaires, you have a massive clinical warning sign. You know their baseline swallowing mechanism is already failing before you even give your first dose of radiation. You cannot simply ignore this warning. You must use this complete data to aggressively initiate prophylactic swallowing exercise and speech therapy. You must intervene and strengthen their function long before the severe mucositis begins. We must now answer a very practical clinical question. How do you actually use all of this PROMs data in your daily practice? The simple answer is that you act before the damage compounds. Look at the red flames on the left side of your slide. This represents severe radiation mucositis. When you start your radical treatment, you know this mucositis damage is absolutely going to happen. If your patient already has bad baseline PROM score, it means their functional reserve is already dangerously low. You cannot afford to wait and watch. You must use these early baseline failures to trigger immediate aggressive action. You must immediately initiate prophylactic swallowing exercises and intensive speech therapy. You must intervene to build and strengthen their swallowing muscles long before the radiation mucositis ever begins. What is the final message with regard to PROM? I want to leave you with one absolute non-negotiable rule. Do not treat the scan, treat the patient. A beautiful radiological response is completely meaningless if your patient is permanently tied to a feeding tube. A preserved larynx is totally useless if the patient cannot speak or swallow safely. First, you must secure your objective scans and endoscopies to perfectly map the true tumor anatomy. Second, you must secure your subjective PROMs to understand the true human burden of the disease. Only when you combine both pieces of this puzzle are you truly ready to plan your treatment. This completes our comprehensive baseline workup protocol. Friends, with this, we have completed our entire baseline functional assessment. We have gathered all our objective inputs from fees, VFSS, pulmonary functions, nutritional screening, and PROMs. Before we close today, I want you to look at the two distinct pathways shown on this slide. You must understand the massive difference between anatomical resectability and functional viability. If you preserve an intact organ that is completely dysfunctional, you are making a fatal mistake. A dysfunctional voice larynx will guarantee chronic aspiration, pneumonia, and permanent feeding tube dependence. A dysfunctional organ will slowly kill your patient. You must understand the true value of a permanent laryngectomy stoma. An upfront total laryngectomy provides immediate airway security and allows for safe eating. It gives your patient a highly predictable survival outcome. A functional neck stoma will let your patient live. This is the absolute core philosophy of our entire oncology practice. Do not treat the scan, you must treat the patient. You must always prioritize function over anatomy. You are now finally equipped to make safe, objective, and life-saving clinical decisions for your patient. Our comprehensive diagnostic workup is now completed. In my next video lecture, we will start discussing the definitive management and treatment of laryngeal and hypopharyngeal cancers. Thank you for your attention today. I will see you in our next clinical lecture. Signing off, Parveen Ahlawat.